Hi, this is E. David Crawford. Joining me is Dr. Matt Rosenberg. Matt brings to us a unique background in that he trained in urology and now is specializing in family practice. Matt has been instrumental in a lot of the discussions ongoing and controversies regarding early detection of prostate cancer. In particular, today, he's going to focus on one of the tenets of the U.S. Services Preventive Task Force and some other organizations dealing with informed decision making. And I'm going to turn it over to Matt right now, who will give us his view on the reality, a reality check really, about informed decision making. Matt, thanks for being with us.
Dave, thank you so much. And you know, it's a pleasure to talk about this because this is such a controversial issue. And to be honest, from a primary care standpoint, this is so easy. And I think we have to realize that we have made prostate cancer extremely confusing. And there are ways to make it simpler. Now, recently, the 2017 guidelines came out for the United States Preventive Services Task Force, and I was very excited. I'm like, hey, there's going to be this great change because it couldn't be worse than the D recommendation, which is not do it. And if we think about the D recommendation from 2012, what happened is a lot of my colleagues in primary care just don't screen anymore because they are told not to. And unfortunately, as you know, we see a lot of patients who have metastatic disease, and we're starting to see a lot more of them. So if we're going to prevent people from getting metastatic prostate cancer, we have to develop a way of screening. So I was very excited when 2017 came out. And then I saw what they recommended. It's a C recommendation. Yeah, I can almost live with that. But then they said shared decision making. And that it is not correct. It's not correct that we should be doing shared decision-making at that point. And if we're going to have this discussion on shared decision-making, let's really understand what we're talking about. There are three tenets of shared decision-making. There's a provision of information, which is balanced and evidence-based, where the harms and benefits of each option are discussed. There's the elicitation of patient's perspective, asking about prior experiences, understanding and discussing concerns, delineating the preferences regarding screening options, and then finally, guiding final decision-making without directing. And that sounds absolutely fantastic if I only see one patient a day. So I can have this long conversation when I really don't need to, because when we're screening for prostate cancer, there's a point to have shared decision-making or a time to have it that's correct. And that's not in the beginning when we look at or we talk about even getting the PSA. That doesn't really even make sense. So let's start at the beginning here. The majority of PSAs, at least prior to the 2012 guidelines from the United States Preventive Services Task Force, were drawn by primary care. We're talking 90% were done by primary care. So if we're doing shared decision-making, we're saying to primary care, since you do the majority of it, you have to be doing this. But if you understand that primary care, either in family medicine or internal medicine, don't get a tremendous background in urologic care, in fact, we're not experts in it at all, then you're taking some really smart people who are specialized in primary care but not in urologic disease, and you're asking them to be specialized in urologic disease and go through all the shared decision-making, which doesn't make sense. So as a result of that, what's happened is it doesn't work, because primary care look at this and say, I don't have all this time to do it, I can't, I'm not the expert, and it doesn't work. And it's not that this hasn't been tried before. It's been tried before in breast cancer, colorectal cancer, as well as prostate cancer, and it just hasn't worked. Most people don't do it. Now, when we look at a national study that was done, and this is in 2015, this is right after the our studies and looking at results after the 2012 guidelines, the bottom line is the results were dismal. I mean, only about 10% of all patients got all the tenets of shared decision-making. 10%. That's terrible. Only 22% said some doctors recommend it and others don't. Only 14% were informed that no one's sure if it's saving lives. So the shared care is not really making a lot of sense in there. Now, I had one of my students in the office recently, and we were talking about shared decision making. And I said, I think the best analogy is I go to the car mechanic because my muffler doesn't work, and my car mechanic says to me, well, let me explain to you what a muffler does, and let me explain to you all this mechanics of it, and then see how you feel about your muffler before you decide whether you want to change your muffler. All right, well, that doesn't make any sense, obviously. I'm giving an exaggeration here, but what I think the specialists have to understand is that primary care, we have a different relationship with the patients. We've seen them I've seen them for 22 years. That's how long I've been practicing. And they come to me for my best advice. Matt, what would you do for yourself, for your father, for your brother, for your family? They want my opinion. Now, when we talk about the PSA, remember, it's prostate-specific antigen. It's not prostate cancer-specific antigen. It is actually a good screening test, but you have to take it with a grain of salt and use it appropriately. I'll give you an analogy. It's like diabetes and the blood sugar. All right, I don't talk to patients before I get a blood sugar. I get a blood sugar at their physical. If their blood sugar is abnormal, then I walk in and I say, by the way, your blood sugar is abnormal. I'm not sure. Let me do some other tests. So maybe that's how we use the PSA. The PSA is not specific, but what do we know? We know at certain levels when it starts to go up, that's when the risk of prostate cancer gets higher. And Dave, you and I have now published several pieces showing that number is 1.5. So when the PSA is 1.5, well, the risk starts to go up. So now the light bulb goes off. Wait a minute. If the risk starts at 1.5, maybe we need to evaluate it differently. Now, the complaint with the United States Preventive Services Task Force, the way we screen is we biopsy, and that doesn't make any sense at all. We actually have tools, the biomarkers, for example, and the MRIs, to be able to evaluate a suspicious PSA, 1.5 or more, before we biopsy somebody. So a smarter way of doing shared decision-making is only do shared decision-making for the patient who is at risk. So the reality of, I'm pointing to a slide here, if your PSA is low right here, what is your risk of prostate cancer? It's minimal. You know what? I don't have to have the discussion with you. It's like when your blood sugar is 85 in the office. I'm not going to talk to you about diabetes because your blood sugar is 85. You're fine. Well, your PSA is 1.5 or low. Your risk of prostate cancer is really low. We don't actually have to have a further conversation. When it's 1.5 and higher, then I can have that decision. And that's not tremendously common. We did a study a couple of years ago where I called up the bioreference lab and I looked at all the PSAs that were drawn in 1 year period, and it was 200,000 plus. And what I realized was that 1.5 was very uncommon. This was the distribution we saw right here. 1.5 is here. And if you look at the data, only 27% had a PSA of 1.5. Now let's put this information together. I should get a PSA. PSA is not specific for cancer. It's prostate specific, not cancer specific. If the PSA is 1.5 or more, which is about a quarter of the patients, now I go into shared decision making. Now I say to them, well, your PSA isn't that high, but, it's at that point that we start to think about, maybe there's a risk of prostate cancer. Maybe I need to evaluate it more. And that's when I do something like I get a biomarker or get an MRI. And again, the analogies with blood sugar. And this is very common in primary care. Patient comes in for the physical. I get a fasting or a random blood sugar. If it's outside of parameters, I don't put them on insulin. I say, you know what, we're going to test it a little differently. I'm going to get a glycosylated hemoglobin. If the glycosylated hemoglobin is suspicious and we consider prediabetes about 5.9 or so, well, then I'm going to look at it and say I'm going to put the pieces together. So the way we should be using this is everybody should get a PSA. Don't have the shared decision-making until it's suspicious. That's 1.5. Then go into shared decision-making and evaluate it appropriately. That's what we should do. And one final point is we shouldn't be screening anybody with a PSA at all unless they're healthy enough that we would do something with the results. So if I have a 50-year-old patient who comes into my office, status post a bilateral BKA, smoking through their tracheostomy tube because they have lung cancer, I'm not going to check his PSA. But if I have an 80-year-old who's healthy on his way to go play tennis with his dad, yes, I'm going to check his PSA. So we should be screening not by age things that are defined by age, but things that are defined by health. And as primary care providers, we do that better than anybody else. Let me, as the primary care provider, determine the health of the patient. Then I'll decide whether I'm going to get the PSA. And then if the PSA is abnormal, 1.5 or more, now I can go into shared decision making and tell the patient what I'm going to do. So the bottom line here, the last thing I should say, the summary point, is the PSA is valuable. We don't want to throw it out. And again, use that 1.5, but use it appropriately. Use that as a defining point to talk to the patient. And again, as I said before, then go into the shared decision making. Dave, thanks for inviting me.